Welcome to the Deep Dive. We're here to unpack compelling sources, giving you the key knowledge efficiently, but also making it engaging.
Exactly. And today, we're looking back, way back actually, into vascular surgery history.
Here we are. It's about an incredibly ingenious solution to a really, really complex medical problem.
Yeah, this is a landmark paper. It's from the 1999 Journal of Vascular Surgery.
Right. The title is Repair of Type V Thoracoabdominal Aneurysm with a combined endovascular and surgical approach.
And our mission today is basically to get inside the thinking behind how these surgeons tackled, well, a vascular puzzle that was just incredibly difficult for its time.
And we've got a great guide for this, a chapter on this very paper from the book 50 Landmark Papers Every Vascular and Endovascular Surgeon Should Know.
It's a fantastic summary.
It really is. Now, when we say complex, you really have to picture this. We're talking about a patient with a Type IV thoracoabdominal aneurysm.
Okay, so that's an aneurysm, a ballooning, stretching from the chest down into the abdomen.
And involving major branch arteries. But, that wasn't even the half of it.
No, not at all. This patient also had aneurysms in the superior mesenteric artery,
Vital for the intestines.
the celiac artery,
Stomach, liver, spleen.
and both renal arteries, both kidneys.
Wow. And on top of all that,
Yeah, there's more. This person had already gone through 2 previous repairs for ruptured intrarenal abdominal aortic aneurysms. Lower down.
2 ruptures already repaired. So you're looking at someone with this, systemic weakness in their aorta.
Exactly. And a really significant surgical history already, which just made the standard options for this new huge aneurysm, well, incredibly risky.
Okay, let's trace the patient's journey a bit. It starts sort of ordinarily with a 61-year-old man, smoker, being checked out for back pain.
Yeah, seems pretty standard, right? But the imaging told a different story.
It showed a contained rupture of an infrarenal AAA,
So a tear, but luckily not a full blowout yet. Urgent repair needed.
which happened at another hospital. They used an infrarenal tube graft.
And the approach they used was transperitoneal, so through the main abdominal cavity.
Okay, so he gets through that. But then, just a few months later, and this is tough, at his son's wedding.
Terrible timing. He gets severe abdominal pain.
Just awful. What was it this time?
It turned out to be another rupture, this one just below the first repair site.
Oh, wow. So back for surgery again.
A second urgent operation, yes. This time they placed a bifurcated graft, like a Y shape.
And they used a different approach.
Yes, retroperitoneal this time,
Ah.
accessing from the back, kind of behind the main organs.
And there was even more history, right? Something about his leg.
That's right. He'd also had an open repair of a popliteal artery aneurysm in his left leg previously.
So it really paints a picture of, widespread vascular problems.
Absolutely. A systemic issue. Which brings us to December 1997, when the authors of this paper first saw him.
What was the situation then?
Well, he now had this 5.5 centimeter type IV thoracoabdominal aneurysm. And the really worrying part was that it involved the origins, the very start of the celiac, the superior mesenteric, and both renal arteries. All of them.
Just tangled right in there.
Completely.
Yeah.
And given that huge aneurysm, plus the 2 prior major aortic surgeries, the referring surgeon basically said
What?
that there were, and I quote, no good surgical options using the standard techniques.
That's quite a statement. It really sets the scene for why something innovative was needed.
Definitely. Trying a traditional open repair for that TAA in that patient, I mean, the complexity is hard to overstate.
Why was it considered so incredibly risky?
Well, because the aneurysm involved all those critical visceral artery origins, right?
Right.
A standard open fix would almost certainly mean complex bypasses to those organs, surgically rerouting blood flow.
And doing that after 2 previous big abdominal operations.
Exactly. The scar tissue, the altered anatomy, it just skyrockets the risk. Massive bleeding, organ damage, potential death is a huge, huge surgical challenge.
So the standard way was pretty much off the table. This is where they came up with
CISA, yeah. Combined endovascular and surgical approach. This was really forward-thinking for the time.
So tell us about the strategy. What was the core idea?
The core idea was, okay, let's tackle this with 2 different but complementary methods at the same time.
Okay.
They planned an endovascular repair for the main TAAA itself using stents delivered through blood vessels, combined with open surgery to debranch those critical visceral arteries.
Debranching. So like you said, building new pathways for blood flow?
Precisely, like building bypass roads. They surgically created new grafts starting from the iliac arteries down in the pelvis
Okay.
and ran those grafts up to supply the celiac, the SMA, and both renal arteries.
Got it. So secure the organ blood supply first with open surgery.
Right. And then once that's done, you can go ahead and deploy the endograft, the stent graft inside the aorta to seal off the aneurysm sac.
Without cutting off blood to those vital organs.
Exactly. And the big win here was avoiding a massive open chest surgery, a thoracotomy, or another really high-risk repeat retroperitoneal operation. Plus, and this is crucial, it drastically cut down the ischemia time, the time those organs were without good blood flow.
Now, you mentioned endovascular tech, 1998. That was some pretty early days, wasn't it?
Oh, absolutely. Options were much more limited than what surgeons have today. Very limited.
What device did they actually use?
And the paper mentions the Corvita endograft. It was one of the few available back then that was, well, potentially big enough and strong enough for this specific anatomy.
A Corvita graft. I imagine these early devices weren't as flexible or maybe as proven long-term as current ones.
That's a fair point. Compared to today's technology, yeah, they were generally stiffer, less conformable, and long-term durability was definitely less well established.
Just getting permission to use it and getting the right expertise, that sounds like a hurdle in itself.
It really was a significant effort. They had to contact Dr. Thomas Panetta, who was leading the national trial for that specific device. Then they had to jump through hoops to get him surgical privileges at UCLA, get institutional approval to use this device outside its trial.
Right, because this was a unique case.
Exactly. They even needed what's called compassionate use approval from the FDA, recognizing how critical and unusual the situation was.
And the patient played a role, too.
Yes, the paper notes the patient was willing to cover the extra costs. It really shows the dedication of everyone involved, the surgical team, the patient, to find some kind of solution.
Truly remarkable commitment. So approvals are in place. They have the device, the expert. Walk us through the actual operation.
Yeah, so first, the open surgical part, creating those bypasses we talked about.
Right, the debranching.
Yep. A graft limb from the iliac artery, tunneled up to supply both kidneys, another bypass from iliac to the SMA, and a third from iliac to the celiac artery.
Okay, all the bypasses are done. Then the endovascular part.
Then they move to the endovascular stage, introducing and deploying two large Corvita stent grafts, 27 millimeters wide, 14 centimeters long, inside the aorta.
The goal being to line the aorta and exclude that aneurysm sac.
Precisely. Seal it off from blood flow.
But you mentioned earlier the aorta itself was tricky, very twisty.
That was a major technical challenge they highlighted. The aorta was highly tortuous, lots of curves.
So snaking these relatively stiff grafts through there, not easy.
Not at all. They actually needed access from two directions. Antegrade, coming down from the axillary artery in the arm,
With the blood flow.
and retrograde, coming up from the iliac artery in the leg against the flow.
Wow. Both ways.
Yes. And they had to use a very stiff guide wire, carefully navigated through all those turns, essentially as a rail to push and position the endografts correctly.
Requires a lot of skill, especially with those less flexible early devices.
Immense skill and precision, absolutely.
But despite all these challenges, the immediate result was good.
It was remarkably good, yes. The patient handled this quite major combined surgery very well.
That's great news.
Discharged after just 1 week in the hospital. And the follow-up CT scans looked great initially.
What did they show?
Complete exclusion of the aneurysm. No blood flowing into the sac. And, crucially, normal blood flow through all those new bypasses to the kidneys and intestines.
A huge initial success then, a real validation of this hybrid idea.
Absolutely. It really showcased a potential new way forward for these super complex aortic problems.
And this story doesn't end there. The follow-up is just incredible. How long did they track this patient?
23 years, which is just amazing data to have.
23 years. So what happened over that very long term? Did the repair hold up perfectly?
Well, interestingly, the open surgical parts, those initial infrarenal repairs, they held up incredibly well. Stable for over 2 decades.
Okay, so the traditional surgery part was durable. What about the endovascular part, the Corvita grafts?
That's where they saw some late issues, which isn't entirely unexpected with early endograft technology over such a long time.
What kind of issues?
After 13 years, he developed a Type 1A endoleak.
Okay, remind us what that is.
That's a leak at the top end of the stent graft where it's supposed to seal against the healthy aorta above the aneurysm. Blood is getting back into the sac around the graft.
Was that fixable?
Yes, they treated it successfully with another endovascular procedure, using more modern device, a Gore C-tag, to extend and reinforce that seal.
Okay, problem solved. But then,
Much later, 22 years after the initial hybrid repair, He developed a different kind of leak, a type 3 endoleak.
Type 3, what causes that?
That's usually a problem with the graft itself, either a defect in the fabric or maybe the connection points between graft components failing.
Likely due to the age of the original device and the aortic changes.
Very likely, yes. The aorta can change shape, remodel over decades, and the old graft components might degrade or separate.
Could they fix that one too?
Yes, again, they were able to seal that leak using another Gore C-tag device placed inside the original graft.
So these late endoleaks really drive home a point, don't they?
Absolutely. It underscores a critical lesson about endovascular repairs, especially complex ones. They often require lifelong surveillance.
It's not necessarily a one-and-done fix.
Exactly. There's always the potential need for reintervention down the line, and both the surgeon and the patient need to understand that from the outset.
So the big takeaway. The hybrid approach worked, it was a lifesaver, but the endo part needed maintenance.
That sums it up well. But look at the overall picture. Despite meeting those later fixes,
Yeah.
this patient lived for 23 more years after an incredibly complex repair that many thought wasn't even possible. At his last checkup, aged 83, the aneurysm sac was stable, no active leaks.
That is a compelling outcome. It really speaks volumes about the power of combining techniques, doesn't it?
It really does. It shows the versatility, the benefits of not being locked into just one approach, open or endo. It's about using the best tools for the specific problem.
Moving away from that one-size-fits-all mentality.
Precisely. And the authors themselves made an interesting point reflecting back.
What was that?
They suggested that even with today's advanced tech, like fenestrated endografts,
Those are the ones with custom holes for the branch arteries, right?
right, even with those, achieving a truly durable long-term result in this specific patient, given how aneurysmal those visceral and renal arteries themselves were, well, it still might have been very challenging. Perhaps less certain than the hybrid approach they took back then.
That's fascinating. It really reinforces the idea that surgeons today need to be masters of both crafts, open and endovascular.
Completely. Knowing the strengths and weaknesses of each, and crucially, knowing when and how to blend them creatively for the best outcome for that individual patient.
This case is just such a perfect illustration of that. The innovative thinking, the careful planning, the sheer adaptability needed for these toughest vascular cases.
It really is a testament to how they could provide over 2 decades of life by adopting this combined approach so early on. It's more than just history, it's a foundational lesson.
A lesson in innovation, even with the tools they had back then, and how those core principles still apply today.
And as we saw so clearly, even with that initial success, the absolute necessity of long-term follow-up, especially for those endovascular parts, it never really ends.
Absolutely critical. So this incredible case, documented so well, it leaves us with a really interesting thought, doesn't it?
It certainly does.
Thinking about how far endovascular technology has rocketed forward since 1998, how might surgeons tackle a similarly complex case today? And maybe even more fundamentally, what are those core principles of truly individualized patient care, the kind these surgeons showed that would still be just as vital no matter how advanced the tech gets?
That's definitely something to chew on, a really profound question to end with.